Cardiac arrest is a sudden loss of blood flow, resulting from the failure of the heart to pump effectively. Signs include loss of consciousness and abnormal or absent breathing. Some individuals may experience chest pain, shortness of breath, or nausea before cardiac arrest. If not treated within minutes, it typically leads to death. The most common cause of cardiac arrest is coronary artery disease. Less common causes include major blood loss, lack of oxygen, very low potassium, heart failure, and intense physical exercise. A number of inherited disorders may also increase the risk, including long QT syndrome. The initial heart rhythm is most often ventricular fibrillation. The diagnosis is confirmed by finding no pulse. 1. While a cardiac arrest may be caused by heart attack or heart failure, these are not the same. Prevention includes not smoking, physical activity, and maintaining a healthy weight. Treatment for cardiac arrest includes immediate cardiopulmonary resuscitation (CPR) and, if a shockable rhythm is present, defibrillation. Among those who survive, targeted temperature management may improve outcomes. An implantable cardiac defibrillator may be placed to reduce the chance of death from recurrence. Cardiac arrest becomes more common with age. It affects males more often than females. The percentage who survive outside of hospital arrest, despite treatment, is about 8%. Many who survive have significant disability. However, many American television programs have portrayed unrealistically high survival rates of 67%. Signs and symptoms. Cardiac arrest is not preceded by any warning symptoms in approximately 50% of people. For those who do experience symptoms, they will be non-specific, such as new or worsening chest pain, fatigue, blackouts, dizziness, shortness of breath, weakness and vomiting. When cardiac arrest occurs, the most obvious sign of its occurrence will be the lack of a palpable pulse in the victim. Also, as a result of loss of cerebral perfusion, blood flow to the brain, the victim will rapidly lose consciousness and will stop breathing. The main criterion for diagnosing a cardiac arrest, as opposed to respiratory arrest, which shares many of the same features, is lack of circulation. However, there are a number of ways of determining this. Near-death experiences are reported by 10 to 20% of people who survived cardiac arrest. Certain types of prompt intervention can often reverse a cardiac arrest, but without such intervention, death is all but certain. In certain cases, cardiac arrest is an anticipated outcome of a serious illness where death is expected. Causes: conduction system of heart, sudden cardiac arrest (SCA), and sudden cardiac death (SCD) occur when the heart abruptly begins to beat in an abnormal or irregular rhythm. Arrhythmia: without organized electrical activity in the heart muscle, there is no consistent contraction of the ventricles, which results in the heart's inability to generate an adequate cardiac output. Forward pumping of blood from heart to rest of the body. There are many different types of arrhythmias, but the ones most frequently recorded in SCA and SCD are ventricular tachycardia (VT) or ventricular fibrillation (VF). Less common causes of dysrhythmias in cardiac arrest include pulseless electrical activity (P) or asystole. Such rhythms are seen when there is prolonged cardiac arrest, progression of ventricular fibrillation, or due to efforts, such as defibrillation, to resuscitate the person. Sudden cardiac arrest can result from cardiac and non-cardiac causes, including the following: coronary artery disease. Coronary artery disease (CAD), also known as ischemic heart disease, is responsible for 62 to 70% of all SCDs. CAD is a much less frequent cause. OFSCD in people under the age of 40. Cases have shown that the most common finding at post-mortem examination of sudden cardiac death SCD is chronic high-grade stenosis of at least one segment of a major coronary artery, the arteries that supply the heart muscle with its blood supply. Structural heart disease. Structural heart diseases not related to CAD account for 10% of all SCDs. Examples of these include cardiomyopathies, hypertrophic, dilated, or arrhythmogenic cardiac rhythm disturbances, congenital coronary artery anomalies, myocarditis, hypertensive heart disease, and congestive heart failure. Left ventricular hypertrophy is thought to be a leading cause of SCD in the adult population. This is most commonly the result of long-standing high blood pressure, which has caused secondary damage to the wall of the main pumping chamber of the heart, the left ventricle. Inherited syndromes, arrhythmias that are not due to structural heart disease, account for 5 to 10% of sudden cardiac arrests. These are frequently caused by genetic disorders that lead to abnormal heart rhythms. The genetic mutations often affect specialized proteins, known as ion channels, that conduct electrically charged particles across the cell membrane, and this group of conditions are therefore often referred to as channelopathies. Examples of these inherited arrhythmia syndromes include long QT syndrome, Brugada syndrome, catecholaminergic polymorphic ventricular tachycardia, and short QT syndrome. Other conditions that promote arrhythmias but are not caused by genetic mutations include Wolff-Parkinson-White syndrome, long QT syndrome, a condition often mentioned in young people's deaths, occurs in 1 of every 5,000 to 7,000 newborns and is estimated to be responsible for 3,000 deaths each year, compared to the approximately 300,000 cardiac arrests seen by emergency services. These conditions are a fraction of the overall deaths related to cardiac arrest, but represent conditions which may be detected prior to arrest and may be treatable. Non-cardiac causes. SCA due to non-cardiac causes accounts for the remaining 15 to 25%. The most common non-cardiac causes are trauma, major bleeding, gastrointestinal bleeding, aortic rupture or intracranial hemorrhage, hypovolemic shock, overdose, drowning, and pulmonary embolism. Cardiac arrest can also be caused by poisoning, for example, by the stings of certain jellyfish, or through electrocution, lightning. Mnemonic for reversible causes. Main article: H's and T's. H's and T's is the name for a mnemonic used to aid in remembering the possible treatable or reversible causes of cardiac arrest. H is hypovolemia, a lack of blood volume; hypoxia, a lack of oxygen; hydrogen ions acidosis, an abnormal pH in the body; hyperkalemia or hypokalemia, both increased or decreased potassium, can be life-threatening; hypothermia, a low core body temperature; hypoglycemia or hyperglycemia, low or high blood glucose. T's, tablets or toxins such as drug overdose; cardiac tamponade, fluid building up around the heart; tension pneumothorax, a collapsed lung; thrombosis myocardial infarction, heart attack; thromboembolism, pulmonary embolism, a blood clot in the lung; traumatic cardiac arrest. Children. In children, the most common cause of cardiopulmonary arrest is shock or respiratory failure that has not been treated, rather than a heart arrhythmia. When there is a cardiac arrhythmia, it is most often asystole or bradycardia, in contrast to ventricular fibrillation or tachycardia as seen in adults. Other causes can include drugs such as cocaine, methamphetamine, or overdose of medications such as antidepressants in a child who was previously healthy but is now presenting with a dysrhythmia that has progressed to cardiac arrest. Risk factors. The risk factors for SCD are similar to those of coronary artery disease and include age, cigarette smoking, high blood pressure, high cholesterol, lack of physical exercise, obesity, diabetes, and family history. A prior episode of sudden cardiac arrest also increases the risk of future episodes. Air pollution is also associated with the risk of cardiac arrest. Current cigarette smokers with coronary artery disease were found to have a 2 to 3-fold increase in the risk of sudden death between ages 30 and 59. Furthermore, it was found that former smokers' risk was closer to that of those who had never smoked. Prevention, with positive outcomes following cardiac arrest unlikely. An effort has been spent in finding effective strategies to prevent cardiac arrest, with the prime causes of cardiac arrest being ischemic heart disease, Efforts to promote a healthy diet, exercise, and smoking cessation are important. For people at risk of heart disease, measures such as blood pressure control, cholesterol lowering, and other medico-therapeutic interventions are used. A Cochrane review published in 2016 found moderate quality evidence to show that blood pressure lowering drugs do not appear to reduce sudden cardiac death. Code teams. In medical parlance, cardiac arrest is referred to as a code or a crash. This typically refers to code blue on the hospital emergency codes. A dramatic drop in vital sign measurements is referred to as coding or crashing, though coding is usually used when it results in cardiac arrest, while crashing might not. Treatment for cardiac arrest is sometimes referred to as calling a code. People in general wards often deteriorate for several hours or even days before a cardiac arrest occurs. This has been attributed to a lack of knowledge and skill amongst ward-based staff. In particular, a failure to carry out measurement of the respiratory rate, which is often the major predictor of a deterioration 50, and can often change up to 48 hours prior to a cardiac arrest. In response to this, many hospitals now have increased training for ward-based staff. A number of early warning systems also exist which aim to quantify the person's risk of deterioration based on their vital signs and thus provide a guide to staff. In addition, specialist staff are being used more effectively in order to augment the work already being done at ward level. These include crash teams or code teams. These are designated staff members with particular expertise in resuscitation who are called to the scene of all arrests within the hospital. This usually involves a specialized cart of equipment, including defibrillator and drugs called a crash cart or crash trolley. Medical emergency teams. These teams respond to all emergencies with the aim of treating the people in the acute phase of their illness in order to prevent a cardiac arrest. These teams have been found to decrease the rates of in-hospital cardiac arrest and improve survival, critical care outreach, as well as providing the services of the other two types of team. These teams are also responsible for educating non-specialist staff. In addition, they help to facilitate transfers between intensive care, high dependency units and the general hospital wards. This is particularly important as many studies have shown that a significant percentage of patients discharged from critical care environments quickly deteriorate and are readmitted. The outreach team offers support to ward staff to prevent this from happening. Implantable cardioverter defibrillator. Illustration of implantable cardioverter defibrillator ICD. An implantable cardioverter defibrillator ICD is a battery-powered device that monitors electrical activity in the heart and when an arrhythmia or asystole is detected, is able to deliver an electrical shock to terminate the abnormal rhythm. ICDs are used to prevent sudden cardiac death SCD in those that have survived a prior episode of sudden cardiac arrest SCA due to ventricular fibrillation or ventricular tachycardia. Secondary prevention. ICDs are also used prophylactically to prevent sudden cardiac death in certain high-risk patient populations. Primary prevention. Numerous studies have been conducted on the use of ICDs for the secondary prevention of SCD. These studies have shown improved survival with ICDs compared to the use of antiarrhythmic drugs. ICD therapy is associated with a 50% relative risk reduction in death caused by an arrhythmia and a 25% relative risk reduction in all-cause mortality. Primary prevention of SCD with ICD therapy for high-risk patient populations has similarly shown improved survival rates in a number of large studies. The high-risk patient populations in these studies were defined as those with severe ischemic cardiomyopathy, determined by a reduced left ventricular ejection fraction LVEF. The VEF criteria used in these trials ranged from less than or equal to 30% in MADIT-2 to less than or equal to 40% in MUSTT. Recommendation for using atropine impulseless electrical activity and asystole. For want of evidence for its use, neither lidocaine nor amiodarone in those who continue in ventricular tachycardia or ventricular fibrillation despite defibrillation. improve survival to hospital discharge, but both equally improve survival to hospital admission. Thrombolytics when used generally may cause harm, but may be of benefit in those with a confirmed pulmonary embolism as a cause of arrest. Evidence for use of naloxone in those with cardiac arrest due to opioids is unclear, but it may still be used. In those with cardiac arrest due to local anesthetic, lipid emulsion may be used. Targeted temperature management, cooling adults after cardiac arrest who have a return of spontaneous circulation ROSC, but no return of consciousness improves outcomes. This procedure is called targeted temperature management, previously known as therapeutic hypothermia. People are typically called for a 24-hour period with a target temperature of 30 to minus 36 degrees Celsius, 90 minus 97 degrees Fahrenheit. There are a number of methods used to lower the body temperature, such as applying ice packs or cold water circulating pads directly to the body, or infusing cold saline. This is followed by gradual rewarming over the next 12 to 24 hours. Recent meta-analysis found that the use of therapeutic hypothermia after out-of-hospital cardiac arrest is associated with improved survival rates and better neurological outcomes. Cooling people in the ambulances, however, no better than cooling them upon arrival at the hospital. Do not resuscitate. Some people choose to avoid aggressive measures at the end of life. A do not resuscitate order DNR in the form of an advanced healthcare directive makes it clear that, in the event of cardiac arrest, the person does not wish to receive cardiopulmonary resuscitation. Other directives may be made to stipulate the desire for intubation in the event of respiratory failure or, if comfort measures are all that are desired, by stimulating that healthcare providers should allow natural death. Chain of survival. Several organizations promote the idea of a chain of survival. The chain consists of the following links: early recognition if possible, recognition of illness before the person develops a cardiac arrest will allow the rescuer to prevent its occurrence. Early recognition that a cardiac arrest has occurred is key to survival. For every minute a patient stays in cardiac arrest, their chances of survival drop by roughly 10%. Early CPR improves the flow of blood and of oxygen to vital organs, an essential component of treating a cardiac arrest. In particular, by keeping the brain supplied with oxygenated blood, chances of neurological damage are decreased. Early defibrillation is effective for the management of ventricular fibrillation and pulseless ventricular tachycardia. Early advanced care. Early post-resuscitation care, which may include percutaneous coronary intervention. If one or more links in the chain are missing or delayed, then the chances of survival drop significantly. These protocols are often initiated by a code blue, which usually denotes impending or acute onset of cardiac arrest or respiratory failure. Although in practice, code blue is often called in less life-threatening situations that require immediate attention from a physician. Other resuscitation with extracorporeal membrane oxygenation devices has been attempted with better results. For in-hospital cardiac arrest, 29% survival, than out-of-hospital cardiac arrest, 4% survival. In populations selected to benefit most, cardiac catheterization in those who have survived an out-of-hospital cardiac arrest appears to improve outcomes. Although high-quality evidence is lacking, it is recommended that it is done as soon as possible in those who have had a cardiac arrest with SUNS elevation due to underlying heart problems. The precordial thump may be considered in those with witnessed, monitored, and stable ventricular tachycardia, including pulseless VT, if a defibrillator is not immediately ready for use, but it should not delay CPR and shock delivery, or be used in those with unwitnessed out-of-hospital arrest. In 2006, the American Heart Association presented the following definitions of sudden cardiac arrest and sudden cardiac death. Cardiac arrest is the sudden cessation of cardiac activity so that the victim becomes unresponsive, with no normal breathing and no signs of circulation. If corrective measures are not taken rapidly, this condition progresses to sudden death. Cardiac arrest should be used to signify an event, as described above, that is reversed usually by CPR and or defibrillation or cardioversion or cardiac pacing. Sudden cardiac death should not be used to describe events that are not fatal. Slow code. In some medical facilities, the resuscitation team may purposely respond slowly to a person in cardiac arrest, a practice known as slow code, or may fake the response altogether for the sake of the person's family, a practice known as show code. This is generally done for people for whom performing CPR will have no medical benefit. Such practices are ethically controversial and are banned in some jurisdictions. Like, subscribe and follow My Health by Dr. J for more health videos. Thank you for watching. Bye.